Corneal biomechanics is absolutely crucial. It is the huge black hole in our current knowledge for refractive surgery, the aging crystalline lens within the eye, presbyopia, and also rigidity of the eye, scleral and corneal rigidity, which has huge implications in glaucoma and the aging eye. So the application of this system is to gain visualization and knowledge of the mechanical structure of the cornea in particular, and also sclera and lens. The reason for that is that the cornea is an elastic structure. We know that. It has much greater elasticity in youth compared to when we get older, our natural cross-linking. And when we perform any mechanical procedure upon the cornea, we have that biomechanical response. We have precision optics for custom ablation, or even just the standard Mundelin-Kunz-Marshall algorithm for laser eye surgery, and also lenticular extraction. But the biomechanics alters that, both short-term and long-term. So knowledge and understanding of the biomechanics is absolutely critical for improving our algorithms and better outcomes. Also, one of the key considerations is astigmatic intrastromal refractive surgery. This has the ability to reduce or eliminate astigmatism for currently up to about 2 diopters, which covers most astigmatism. And multiple regression analysis on current nomograms and algorithms shows that 50% of the standard deviation, 50% of the noise, is biomechanics. And the best we can do presently is to look at gross elasticity of the whole cornea, which we plug into a nomogram with age, or with scans such as Corvis. But the BOSS scanner gives us a complete and very detailed knowledge of biomechanics at each level within the cornea. So feeding this data into future AI-driven algorithms and nomograms should mean that we improve our standard deviation by 50%. That is a huge improvement. Much more predictable for patients and much better outcomes for us as refractive surgeons. I think in the beginning, the first thing will be the data, absolutely platinum level data sets, which are then plugged into AI algorithms for refractive surgery that will convert this instrument from a would-like for academic institutions and so forth to a must-have for the standard refractive surgeon, because your outcomes will be better. It's as simple as that. The second thing then will be the investigation of the sclera, its biomechanics, and how that integrates with glaucoma, also myopia development. We also have a fascinating area with the ability to measure the longitudinal elasticity of the natural crystalline lens. And I personally believe, but can't prove this yet, that there are 2 forms of presbyopia. I feel that there are those who've had exposure to significant ultraviolet light, particularly in youth, where children in bright light environments are playing outdoors with no sunglasses and get a significant lifetime UV exposure. That crystalline lens becomes stiff, cross-linked, early presbyopia, light scatter, and essentially will progress to cataract at a much, much younger age. And then we have the second form, which is natural aging, where the lens inside our eye continues to grow and the zonules become less effective, hence classic age-related presbyopia. Now, if we can differentiate the two, we can say to patients potentially, well, your lens is aging and it's going to progress to light scatter and essentially cataract in a fairly short space of time. Alternatively, we can say, well, actually, it's pure presbyopia, and our treatment algorithms or our advice as to whether to have a surgical option or a conservative option may well differ. So I think this instrument will be deterministic in deciding which route we plan treatment and advice for individual people.